I'm going to put you each on the spot in closing. If you're like me, you got patients, you're both tempted to get these tests, and you get patients who bring them into you. The gene profiling, molecular profile test, whether it's a next-gen sequence or a protein analysis or some combination of those. And it sort of feels like you have to respond to it in some way. And there is emerging data, Cosgrove's study and others, that said if we do pay attention to this, we might in fact be doing better. How are you handling that? And each of you answering essentially the same question, and take it on up, if you will, to where should we be going with these kinds of analysis? And Fadi, I'm going to start with you. Molecular testing in everyday clinical practice.
Yes, next gene sequencing is probably unbiased, the way to go. And the idea is to try to identify patients for clinical trials, even early clinical trials, as early as phase 1, not just as a last resort, when the patient is fit and when they can keep some backup plans with commercially available drug. I think it's the way to go. We have to understand, sit with payers and healthcare providers how to standardize it and make it cost effective.
Yeah, so you're in. You think we should in. Axel?
It's the problem is really you can't ignore it. Patient sits in front of you. I have this mutation. There's a drug, that's approved in, I don't know, melanoma, for instance, the trametinib. Why don't I get the drug? And eventually we cave in spite of the fact that we might know, from sun data that it might not be as effective. Now, what I think we need to do is document really what happens, really get a better read about, what are the consequences? Do patients get more into clinical trials? Will they get a kind of off-label drug? Will these payers be willing to listen to us? They will only be willing to listen to us for some time until we document that this really makes a difference in patient outcomes. So we need to document that this really changes patients.
So that's kind of partnering with the payer, is what I'm hearing you say, that if the payer says fine, but in exchange for data,
need information
on the other side.
And if you were the payer, wouldn't you like to see that?
Absolutely.
We need to do this because these drugs are not without toxicities. Yeah. Not just financial toxicity to the system, but also real toxicities for the patient.
And do I need another biopsy? Can I use the 3-year-old primary?
That is, at Mayo, we are, when we put patients on next-gen sequencing, whatever, we actually require a new biopsy.
Tony, I know you guys have led the way in a lot of studies requiring enrichment, I know, because we're doing studies together. What's your take on profiling? How are you all handling it right now?
So, this is the era of personalized medicine, or so we're told, and it should be. And as everyone's saying, there's this challenge. The challenge of when to get the test and what kind of test to get and what kind of tissue you need. You need a fresh tissue or a paraffin-embedded tissue, and can you apply what happened 2 years prior to what's happening today? And of course, these are challenging, but I think the biggest challenge, as Axel noted, is, so what do you do with all these mutations? Because a lot of mutations rise up when you get a report. What do you do? How can you make sense with these mutations? And a lot of these tests actually give you options about drugs that link up to these mutations, although mostly non-validated. And thus the challenge. So some of the things we're doing are exactly what Axel is referring to. So we're working with a certain company that deals with these tests to actually try to understand how they change behavior. At this point of time, we don't have that data. We don't know what to do with it. 2, we also need to understand whether we're making a difference. Are we, ordering a $5,000 test and a $5,000 biopsy, in some places $16,000 biopsy, to actually change outcome? Are we getting any benefit from the data? Are we collecting it? So right now, what we're doing at The Ohio State University is actually, when we do these tests, we're very cautious, and we're using them mostly in the setting of, one, understanding the behavior changing element of it, and 2, actually making as many clinical trials, phase 1 trials, available to our patients that do require the presence of certain mutations and link them up to these agents.
Yeah, I recently visited our friends in Nashville, and at Vanderbilt, when you open up their EMR, it's vital signs and gene mutations that are in their flow sheet, gang. Now, I said, what are you doing with that? They go mostly skipping over it. Alan, I'm going to make you on the hottest spot. So I've just made you czar I'm from Washington, I can do that. You don't have to ask anybody's permission, CTEP will buy. What is the strategy, if you could build it, to sort of begin incorporating and studying this? What do you dream about?
Well, I think, so the first question is, I think we should answer the question, is looking at the primary any different than looking at the metastasis? There's a lot of play now about biopsying metastases. Well, which metastasis? Because there's great variability from one metastasis to the other. So first I would address the question, do we really need to do subsequent biopsies? Is there much information gained by doing biopsies in metastases? Because we are treating metastatic disease. I would profile every patient who comes in the door, and I would have, most of that might be for reference, because it might inform how patients do in looking backwards as well as looking forwards. And then as you characterize the cancers and get a sense of what the common mutations are or how the disease behaves, you could further on down the line take another agent and put it into play. I think the trick, none of us believes that a single mutation is the driver mutation. This isn't GI stromal tumor. And so the problem is going to be combining these agents, and how do we do that? So if I was czar, I'd also
You are czar, I made you
Thank you, I'm czar, so I would have the FDA enable us to combine these agents without going through having to do handstands, with the possibility of taking these drugs and putting them in combination. Now, how far will we go? I don't know. But again, who would have thunk 5 or 10 years ago that crizotinib and erlotinib would be treating patients with lung cancer and make colon cancer look like we're backwoods? Yeah. So.
Gang, I just can't thank you enough. It's just a wonderful exchange. I learned so much, and I think we learn a lot from each other and our different perspectives, bringing it all together. Thanks for flying to my neck of the woods to film this together. I appreciate your doing it. And I really would like to thank all of our gang out there who's joined us for this panel discussion. I hope it'll make you a better colon cancer doctor. Thanks.